All right, good morning, everyone. My name is Kevin Corbett. I'm the CEO of the Healthcare Authority and also the Secretary of Health and Mental Health here in the state. Thanks for being here today in person, and for those online, I appreciate your time as well to learn about our new managed care delivery system in Oklahoma. I also want to thank the Kingfisher County Fairgrounds for their hospitality and hosting us. Joining me today are my colleagues from the Healthcare Authority. They'll introduce themselves here in just a minute, as well as our partners from our health plans that are going to be part of our managed care delivery system. And I hope you'll take the time to visit with them today. For those that are here and anyone online, we certainly have the opportunity to ask any questions of our plans as well. So here representing the plans are Blue Cross and Blue Shield of Oklahoma, Oklahoma Complete Health, Humana Healthy Horizons, United Healthcare, as well as our dental plan representatives from DentaQuest, Liberty Dental Plan, and MCNA. So today I'm going to give you an opportunity to understand what we're really talking about with regards to SoonerSelect, which is our new managed care program. And after we go through that, I'll open it up for Q&A, and all of our colleagues here have the opportunity to answer any questions you may have in person or online. Before I start, let me also talk about something that's really coming to us here very shortly, and that's expansion. So our Medicaid expansion program. As you recall, the voters in the state did pass State Question 802. That allows us to start to serve adults 19 to 64 years of age that we currently do not serve in our Medicaid program. Just a little bit about dates on this. We will begin to offer benefits to this population on July 1. That's assuming that they are eligible for benefits, and the eligibility process will begin with an application process that will begin June 1. So June 1, we will start the application process for about 200,000 Oklahomans that will now have access to Medicaid benefits and begin to receive those on July 1. So I wanted you to be aware of that. That's something that we're certainly working on as we work on our managed care delivery system as well. So as a managed care organization and a managed care delivery system, our partners are health plans, if you will, or insurance companies that are responsible for coordinating health services for our Medicaid members. They provide whole person care in support of our members in obtaining the needed medical, dental, and behavioral health and referral services that they desperately need. 40 states do this already and have had great outcomes with regards to quality improvement, access to care, cost predictability, and savings. The participation in our program, again, SoonerSelect, begins with our eligibility categories. And that's about 800,000 of our members today will be part of our program. Largely our low-income parents, our pregnant women, our expansion population, and mostly children. Now, the enrollment for this process will be mandatory for that population, with the exception of one population. That's our American Indians. They'll have the option to join the plan as well. Now, this plan, the SoonerSelect program, will begin October 1. So I mentioned expansion. Starts July 1 as far as benefits, application for expansion June 1. This move to managed care will be October 1. So a lot is going on with regards to our program at the state. As you probably have heard many times, Governor Stitt is certainly dedicated to pursuing the SoonerSelect program as one lever to improve health outcomes in Oklahoma. It's been said many times that we are 46th in the nation with regards to health outcomes, and there is a need to really change that. And his support for this initiative is unwavering, as I mentioned many times before. We also recognize that we don't do this alone. The Medicaid program has the pleasure and the benefit of being served by over 60,000 providers in the state of Oklahoma. And we need their expertise and their contribution to make this program work. And we knew their input and advice was important to our program. So back in July, we did go through a process of seeking input, seeking questions, seeking answers with regards to moving to managed care. We got about 100 responses. That means 100 individual responses with many questions and suggestions. Most of those were considered and included in the program that we've designed today. Continuing that spirit, we're also holding these town halls. This is the 4th town hall we've held, and we'll hold more, to really answer the questions for providers with regards to how this will work for you in serving our members. As I mentioned, we're going to have 800,000 members moving to this program. About 200,000 of them will be adults that we've not served before in the past. So we hope the providers will have the opportunity to take every opportunity to contract with our MCO partners. I think this will be a great opportunity to create access for care for our managed care members, or Medicare members in our communities. So before we start with Q&A, let me introduce the panel or have them introduce themselves, quite frankly, and give you a little bit of information with regards to kind of the features and provisions within our contracts with our managed care partners, how that will impact you with regards to timely payments, credentialing, and things of that nature. So Melody, may I ask you to start, if you would.
Good morning, Melody Anthony. I'm the State Medicaid Director and the Chief Operating Officer.
Good morning, Trailer Rains, Deputy State Medicaid Director.
Good morning, Aaron Morris, the Chief Financial Officer for the Healthcare Authority.
Good morning, I'm Dr. Karen Luz, the Director of Dental Services, Healthcare Authority.
Terry Cothran, the Pharmacy Director at the Healthcare Authority.
Good morning, I'm Dr. Nathan Valentine, Chief Quality Officer.
And I'm Dr. Mike Crinden, I'm the Chief Medical Officer.
Okay. So Melody's going to give you a little bit of a summary with regards to the provisions of the contracts that I'm sure all providers will be interested in knowing.
So, again, very happy to be here. I don't know how many of you that are attending are actually providers for senior care, but we do want to make sure that if you are a provider or if you know a provider, please help us help them understand that according to the contract that we have signed with our new managed care partners, that we are maintaining everything that we do today, meaning that everyone will need to be contracted with us and contracted with a plan. We pay claims every week. The plans will be paying claims every 2 weeks. We will require prior authorizations today. They will require prior authorizations. We have authorizations, as you know, for in medical, in dental, and some of our behavioral health initiatives require prior authorization. So if you look at your services today as a provider, or even as a member seeking care with one of our providers, when you have your care delivered by a managed care partner, the benefits are the same, the processes are the same. And so we are reassuring everyone that we talk to that if there is any deviation from what we have agreed to do with this managed care partner delivery system, that we will intervene for all the members and for all the provider community. So we are trying to make it as stabilizing as possible for the people and the providers that we serve today.
All right, thanks, Melody. I know that everybody has some questions. I'm going to ask Melissa Ritchie to come up. Melissa's our Chief of Communications. She's going to moderate the Q&A. I'm going to join the table here to participate in the Q&A.
Thank you. We will now open the floor to questions for our panelists. So please raise your hand if you have a question and I can bring the mic to you. For those of you joining us virtually, please submit your question in the Q&A section. I will ask our panelists those questions as well as our online monitors. We'll try to get to those questions as they come in. Do we have any questions here in person right now? Oh, we do, okay.
Will reimbursements be the same through the plans that they should be exempt?
So yes, within the contract, we set certain floors for reimbursement that they couldn't go below. Now, I would say not all services have floors, but we have talked to our partners and they have let us know that they, for the most part, plan on reimbursing the same as we do for our current senior care program. How much you have one of those?
Okay, we're going to ask a couple of the virtual questions that we have coming in. What are the changes to dental benefits?
There are no changes to the dental benefits. Everything that is covered now under Sooner Care will be covered under SoonerSelect with our plans. So that's laid out in our RFP. And again, so all the services that are currently covered will continue to be covered.
What is the process for our clients to pick their SoonerSelect partner?
So I'm gonna add just a little bit what Dr. Lou said. There will be changes just in terms of early identification, more a focus on prevention services. Throughout, history in the Sooner Care program, we've done a really great job in getting it where it is right now, but we still don't have a great penetration rate for dental utilization across our adult and children population. So we're really leveraging our 3 dental partners really to do a lot more outreach, early education and identification of dental issues. That way we can prevent more intensive or invasive dental procedures later in life.
Mel, do you want me to repeat that question or?
Yes, please.
Okay.
We're fighting over the mic, can you tell?
What is the process for our clients to pick their SoonerSelect partner?
Great question. So we will, around July 1st, we'll start sending notices out to all of our members who are eligible for SoonerSelect. As Kevin mentioned, that's around 800,000 individuals that will get a letter from us. It will ask them to go to mysoonercare.org on or about August 1st and log into their account. At that point, we will have a plan selection module within there that they can choose their managed care partner. Right now, what our portal looks like is they go in there and choose their primary care provider. So instead of doing that, they're going to choose a plan. And then once they go to the plans portal, they'll choose their primary care provider there.
Okay, how does this managed care transition affect Medicaid patients admitted to the hospital?
Well, I guess it shouldn't affect them at all. What we're doing is we're making the program mirror what we do today. So if you are a Sooner Care member and you go to Kingfisher Hospital, the hospital will be contracted with our plans, and you will receive medically necessary services just like you do today. There will be no changes. Yeah.
I do want to add that many of the plans do intend to have care coordination and transition of care type services for those Sooner Care patients who are admitted to the hospital. So even though reimbursement and that sort of thing will not change, there will be added benefits to those members, Sooner Care members that are admitted to the hospital, with enhanced services to help them coordinate for discharge planning and transitions of care and things that they may need that we simply don't have right now.
For those members that already have a provider, if they have to select a plan before selecting their provider, how will it prevent them having to switch providers if the plan they select then is not contracted with that provider?
So we are currently working on a staffing plan within the healthcare authority and our contracted member services call centers to train them on choice counseling. So when they get that letter from us, there will be a member services hotline they can call to ask any questions. By that point, we will have a pretty good adequate network from each of our plans. So they can say, I'm with Dr. John Smith, which plans is he aligned with? And then we can say, let them know that they can make an informed choice that way.
Will clinics be able to assist with enrollment for our patients?
Absolutely. Guessing that question is in regard to expansion. And so, yes, we have been working with a lot of our safety net clinics, like our family qualified health centers, community mental health centers, and other agency partners to give them all the information they need around income limits for various family sizes, how to access mysoonercare.org. Currently, if you go to mysoonercare.org, we have a lot of video tutorials and information on what documents you'll need whenever you sign up.
Will the rollout of the expansion program impact the rates of uncompensated care for hospitals?
Absolutely. I don't have a dollar figure, Aaron may, but we're talking about adding, having insurance coverage for around 200,000 individuals in the first year that were currently uninsured. So that's Sooner Care dollars now being able to reimburse for what would have been uncompensated.
Anybody else here in person that has a question? Okay. Can you provide an example of how managed care has worked in other states?
Okay, we'll probably all take a crack at this. I know that Dr. Herndon and I have been asked this question before. So the thing that they bring to the table that works in other states, that we know will work in our state because of past history, is the fact that those plans have the ability to provide services that a Medicaid agency cannot provide. Because federal regulations say state Medicaid agencies can only provide medically necessary services. But they also say that a managed care plan for Medicaid members can provide what they call value-added services, which means they can be in a community working with people on Sooner Care, and someone goes into a provider's office or an FQHC or a hospital, and they can talk to them about community resources that are not medical in nature, like food insecurity, transportation, incentives for them to do prenatal care. I think we mentioned in some of our other town halls that the plans have the ability to work with those newborn babies and get them a car seat or a crib, things that we can't possibly do. So that has proven in other states to add extensive value to the population that they serve.
So Oklahoma participates with what's called the Medicaid Medical Directors Network, which is a network of chief medical officers, medical directors for state Medicaid programs. And so I get to hear the success stories of my peers who have managed care within their state. And just to be honest, I'm quite excited that Oklahoma now has the opportunity to do some of that innovative stuff that I've been hearing about for years. And I'll just, to not monopolize the conversation, just to say that one of the things that I'm most excited about is the ability to do peer support services and to deal with opioid use disorder and the opioid crisis. Many states have done many innovative things. I'll call Pennsylvania to light. And with their managed care organizations, they have done some incredible things that have really reduced the opioid epidemic in the state of Pennsylvania, and not just to decrease opioids by putting restrictions on the prescriptions, because that can lead to abuse of other substances. But in their state, they have done some very innovative things that not only have reduced the opioid utilization rate, but have reduced the opioid overdose deaths and addiction to substances across the spectrum. So I could give lots of other examples, but that's one of the things that I'm most excited about, that managed care has worked in other states.
I'll just add to that for dental. I've also spoken with a lot of my peers in other states, state directors, and they have all had really great things to say about how these various plans have improved outcomes for their states through the value-added programs. So they do provide sometimes benefits that Medicaid cannot, in Oklahoma, cannot supply. Some of the things they've done is increased tremendously the number of sealants that are placed on children's teeth, which Oklahoma really strongly needs to increase that, and the number of fluoride varnish applications that are provided. So through both primary care physicians and dentists. So it really helps to reduce caries in children.
Do providers have to pick just one plan?
Absolutely not. We're actually encouraging participation with all of the plans. And I will say, although the folks you see in this room are technically competitors, they're working together very well and efficiently to make sure that the provider experience is as efficient and seamless as possible as we not only transition from Sooner Care administration to a plan administration, but also plan to plan as well. So we encourage participation with all of our partners.
Will Title 19 now be extended to adults with SoonerSelect?
So Title 19 is our federal coverage for Medicaid in Oklahoma. Yes, it'll be extended to adults through Sooner Care expansion July 1st. Those newly eligible adults, the 200,000 or so individuals, will transition into SoonerSelect as a service delivery model October 1st.
Will occupational care assistants be able to provide therapy through all 4 plans?
Yes, everyone that is that can be reimbursed now for services will be covered through one of our plans.
Do referring PCPs need to be credentialed with the MCOs for our specialty clinic to get paid for pediatric therapy?
Yes, rendering providers will need to be credentialed through each of our plans that they want to participate with. Again, I'll say that we will have a uniform credentialing application so that a provider is not having to do separate credentialing intensive process with each of the plans, but it's going to be kind of a 1-2-pager form that they can fill out.
Has anyone heard if telehealth teletherapy will be extended past 4:30?
We are still waiting. So that's in regard to the public health emergency that's currently through the end of this month. We're still awaiting official CMS guidance that will be extended. The president did indicate that he intends to extend it through the end of the year, but he technically only has legislative or congressional authority for it to extend per quarter. So we believe, expecting that to come.
How often?
Let me make a comment on that, right, Melody. Just to give you context, the state did some phenomenal things to react to the pandemic and the public health emergency, and telehealth is certainly one of those. And we certainly spent a lot of time working with our federal partners to be able to do that in the state of Oklahoma. Just for context, the 12 months prior to the pandemic, we probably had something in the neighborhood of less than 10,000 televisits that took place for the entire year. We have certainly crossed in the next 12 months the 1 million mark, and probably going to go to the 1.5 million mark where we are today. So we look at this as not only something that we needed to do from a pandemic standpoint, but also if you think about what's happening in Oklahoma and the lack of access to care in rural Oklahoma, telehealth has been a real game changer for us. And we certainly support the use of that. I think our providers support that. I think our members support that. I know there's still some contingencies with regards to being allowed to do that. I'm fairly confident that the evidence will suggest that this was just not a pandemic response. This is a healthcare access response and needs to continue for the foreseeable future, if not for the entire future.
We did have our dental focus group meeting 2 nights ago, and our dental partners were there, and it's definitely a strong intent to continue many of the telehealth services that we did not cover prior to the pandemic. I think we all realize and are excited about the fact that there are telehealth services that can prevent emergency room department utilization, for example. And truthfully, people who may have transportation limitations, who can't get service, and that service could be met through a telephonic or even a telehealth visit, and perhaps even a telephonic visit. So we're excited about the potential to expand that. To say that every code that is open right now is an unknown to us post-epidemic, because right now we have opened many codes, CPT codes and services, but the intent is to continue to provide an expanded array of telehealth services post-pandemic. And I do think, agreeing with Kevin, that we've not only seen a significant increase in utilization, but what we believe is an affiliated reduction in some other services prevented by the telehealth business.
Sure, I'll just add that I know some of the plans have spoken with me and told me some of the innovative things they've done with telehealth, again, more than what we can do, like having a dental hygienist on board to answer questions. And as Dr. Herndon said, keep people out of the emergency room. And I think that plans will probably continue to do that as well after the pandemic.
And Melissa, I want to go back to a prior question on enrolling, providers enrolling with multiple plans. Trailer mentioned we encourage that and absolutely do. It's important for all of our providers, but it'll be specifically important for certain providers that will participate in our transitioning supplemental payment programs that we'll call directed payment programs, which will be our hospitals and our affiliated physicians with public medical schools. For them to maximize the revenue or their potential revenue, they'll need to participate with each plan. So just a comment that for hospitals, affiliated physicians, CMHCs, potentially a couple other provider groups, be very important that you enroll with each plan.
How often can patients change the plan they're on?
So initial enrollment will begin 8/1. An individual will have between August 1st and about September the 10th to make that initial choice. If they haven't made a choice by that time, we'll do an auto assignment to a plan. It's going to be a very basic round robin auto assignment until everyone that's eligible for SoonerSelect is assigned. Once they're assigned, they'll get a letter letting them know, and then they'll have 90 days to change plans. And so within that 90-day period, they can change a few times. After the 90-day period, they are locked into that plan until open enrollment. The steady state open enrollment period will begin May 1st of every year. That way we're back to a state fiscal year, which is July 1st to June 30th every year. That'll be our plan year. So then they'll be able to change, as with commercial insurance, every May.
Okay, Dr. Cawthorn, I have a couple questions for you. Will retail pharmacies that are currently contracted with SoonerCare need to proactively reach out to each PBM to get contracted, or will they reach out to us with a request for pharmacies to sign a contract?
They will need to be contracted. I do not know the answer about who reaches out to whom. Do you know, Trailer?
The plan should be actively recruiting, but it never hurts for them to reach out to any of our partners.
Yeah, most of these pharmacies are going to be fully aware of who these plans are and probably already have similar contracts in place, so it shouldn't be an issue.
Will retail pharmacies that are currently contracted be ensured preferred provider status, or will members be directed to preferred pharmacies such as CVS, Walgreens, to the exclusion of non-preferred pharmacies?
No, there won't be a preferred status similar to that. It'll be like it is today, that they'll all be equal in their roles. So no steering or preferred pharmacy directing.
Thank you. Thank you. In person, have any other questions? Okay, we're going to stick with our virtual questions. Will families be auto-assigned to the same plan or potentially be in multiple plans?
Yes, families, if we're auto assigning and they are known to us as a family unit, they will be assigned to the same plan.
Okay, this is a long question, so hang with me. We are a hospital in Texas and get significant volume from SoonerCare members. We have been told by some plans they will not contract with us because we are not a priority. How do you plan to maintain access to members that go live with significant providers excluded due to being out of state, even though we are key to servicing your members?
So what I will say is I've heard of some of these issues being communicated back to us, and I just want to reiterate that we are in constant contact with the plans that you see in this room. We have weekly meetings with plan CEOs. We have implementation work groups that we work with implementation staff daily, probably 30 to 40 hours a week. And so as we get these requests, we reach directly out to the plan CEOs and say, you have an issue with your contracting center because they're giving wrong information. If we have out-of-state providers that we currently rely on in large volume to serve our clients, as we know, it's easier for someone up in the Panhandle to go to a hospital in Amarillo potentially, or someone that's on the southern border to go to Dallas maybe. We value those relationships, and so will our plan partners. And so we're continuing to work with them around their call center responses. You have to remember too that they're in the the process of establishing their Oklahoma-based call centers, provider reps, et cetera. So until then, they're using a lot of national contracting agents, which are trained on their various markets. So there's going to be some miscommunication, and our apologies for that. But any instances like that, please feel free to reach out. So we'll troubleshoot, but we are constantly working on improving responses like that.
For NCO patients that are hospitalized, do their inpatient physicians need to be contracted with the NCOs individually to get paid for their inpatient services?
All providers need to be contracted and credentialed.
Is there consideration for additional citizenship verification documents to be added, such as a social security number?
We are not changing anything from what we currently require for Sooner Care membership through mysoonercare.org. So what is required today will be required July 1st for expansion as well.
We don't have any other questions coming through online for our panelists. Is there anybody here in person that has any other questions?
As a provider, if we are contracted with this one plan, will the Sooner Care members have a card that says which plans they have, so we know whether we can take them or not?
They absolutely will. So if, for example, they are with Humana, they'll have a Humana card that will show that they belong to that plan. And I will say too, if you only choose to go with one plan and you have a member that's aligned with a different plan, there's still an opportunity for you to provide services to them, but you may be considered an out-of-network provider, for example, and have a different reimbursement rate.
Are Indian tribes exempt from having to sign up with providers?
That's a little complicated of a question, but I'll do my best. For our American Indian, Alaska Native members or individuals, they can choose to opt in to SoonerSelect or SoonerSelect and choose one of our partners in the room to provide their coverage. If they choose not to and they receive their care from a tribal provider, they can do so and we will still directly reimburse that tribal provider. Even if an American Indian opts into SoonerSelect, we will directly reimburse that tribal provider. Where it gets a little complicated is a lot of our tribal partners work to serve and provide services to those non-American Indian individuals. And so that would be an individual that goes into their clinic that does have SoonerSelect. For those individuals, they would need to contract with the plan in order to be reimbursed at the full rate.
In the optometry world, many of the commercial health insurances have a contract with a specific commercial vision insurance. Will the current SoonerSelect providers have a separate vision plan with SoonerSelect, or will SoonerSelect patient plans be administered through the health insurance provider's selected vision insurance provider?
So the contract we have is with the folks you see in the room. Some of them will utilize subcontractors to manage some of their service delivery, such as maybe behavioral health will be a separate company. We do have, I believe, 3 of our plans use subcontractors for vision, but ultimately reported through and are monitored by the overseeing plan as well as the healthcare authority. So you may get outreach materials from subcontractors that you don't recognize the name of, but they are going to be aligned with one of our form national plans. We are working to enhance our SoonerSelect website through our web portal to really get more information and contact information about those subcontractors so they're more familiar to you.
When will we have access to provider training through the MCOs, specifically how to submit prior authorizations?
We had that conversation this week in one of our work groups. As the plans build out their local Oklahoma offices, they will provide technical assistance in how to submit billing through their portals. And they will have, it's really baked into their current processes to have this option available. We have, I heard from one of our dental plans that they already have a YouTube channel set up if you want to go ahead and start looking at, how to bill through their plan. So we expect probably around the July mark, as we start building out and having our final network established, that they'll really start intensive training on the ground.
How will the managed care plans reimburse federally qualified health centers?
So we have required within the RFP that they not reimburse our FQHCs any less than their current encounter rates. Now, what I will say with that is I understand that they also have flexibility to negotiate with the FQHCs on new payment methodologies and value-based payments. So an FQHC can always enter into a new billing arrangement with the network, but they cannot reimburse less than the current encounter.
Will there be anything on the insurance cards that alert us to know just by looking at the insurance card that the patient is a SoonerSelect patient?
It'll say SoonerSelect on them somewhere. They'll be branded by the plans in the room, but it will say SoonerSelect on them.
Do we have any other questions from our audience here in person? Okay, you guys have done a great job at answering questions. Dr. Herndon, I think, has a few comments to make.
If it's okay, just because improvement in quality outcomes is so critical and at the core of why we're doing this, I'd like, if it's okay with Kevin, just to let Dr. Valentine give a 2-minute snippet of what the quality components of this conversion to managed care would look like and the requirements that will be, and federally, be placed on them and kind of what that would look like for us. Do you mind doing that, Dr. Valentine? Sorry, picture the spot. If you measure plots and pits and buckets.
Sure, so get the mic right spot. So there's a lot actually. It's exciting in the quality improvement area. There's a requirement for a quality assessment and performance improvement plan on a yearly basis. There are requirements for ongoing what we call PIPs or performance improvement projects, which are very deliberately well thought out quality improvement projects that target specific needs in the population. Examples might include improving how consistently and how reliably our mothers who deliver get back in for a postpartum visit, or maybe the quality of that visit. They can also include things like shoring up the social supports that are in place. For example, making sure that there are courses available to our members to learn the techniques that are evidence-guided that increase stability in the home and therefore improve economic status and ability to get in for preventive visits. All of these things, there's a host of federal requirements that have been put in place over the past decade or so that really have helped us end up with a lot of tools for quality improvement. And they culminate in things you see in other states, like in Georgia, twice as likely to have the right number of preventive visits in the first 15 months of life than if you're on fee-for-service. I mean, there's things like that all over the country, examples like that all over the country. And so we're looking forward to utilizing all those methods and tools with this new plan.
We've had a couple more questions come in from our virtual audience. Will there be any changes to visit limit allowed, or how often evaluations will be covered?
So current limits will be in place. Now, I will say that our partners have the option, as Melody alluded to earlier, to give value-based or value-added services that can go above and beyond what we currently provide.
Okay, we're going to have one more last question. When we check eligibility, will it show which plan they have?
Yes.
Oh, we have one more coming in, I'm told to ask. Okay, what about facilities who get a revenue code payments? Will that continue for the expansion, or will IHS facilities be subject to a fee schedule as well? If so, where will we find that fee schedule?
So it sounds like it's coming from a tribal partner. And so I will say that if a tribal facility is providing services to an American Indian Alaska Native individual that is eligible for their OMB reimbursement or encounter reimbursement, they will continue to receive that. We're not changing that process.
Thank you.
All right, thank you everybody for participating today. We really appreciate your attendance. As I said, we'll have the opportunity to have more of these town halls. We're recording this one as we have 3 that we've already had, and we'll post questions and answers on our website. So please look out for that. I just do want to add on to one thing that Dr. Vernon mentioned. If you ever have the opportunity, I hope you'll take the opportunity to come to the Healthcare Authority and visit our boardroom. You'll see our vision statement. And it's something that we all know and we all are committed to. And that vision is for all Oklahomans to be healthy and have access to quality healthcare regardless of their ability to pay. This is our opportunity to really, really make a further commitment to that. And we're very excited about the opportunity to really demonstrate that for the citizens of Oklahoma. This is a large project that we're undertaking, a large transition, a lot of work's gone into it. The team at the Healthcare Authority is working day and night, doing a fabulous job. And I hope the provider network that we're so lucky to have today will join us in this cause. 46 in the nation, I don't know about you, but that's just not something to tolerate any longer. And I think we have the capability of changing that, and this is our commitment to doing that. So thank you for being with us today.